Okay, let's go ahead and get started. Good morning, everybody, and welcome to today's Pain Management Echo Clinic. As always, we will start the session today with introductions, and then we have a case from Dr. Dalton to review, and then we will get into the didactics from Dr. Patterson. So for introductions, my name is Neha Sharma, and I'm the program coordinator for Project Echo Nevada. Mike, can you introduce yourself?
Good morning. Hello, everyone. My name is Michael Lewandowski. I am a pain management psychologist, and I have been working with people with persistent pain for the last 35 plus years, and have enjoyed working with people, helping them. I'm on the University of Nevada's Medical School, Department of Psychiatry faculty, assistant clinical professor, and enjoy the ECHO project and welcome everyone. Thanks,
Mike. Paul?
Well, good morning, everybody. My name is Paul Snyder. I'm licensed to diagnose and treat mental health disorders as well as substance use disorders. I'm a clinical faculty for UNR Med and also a course director at UNR Med, as well as a clinician for underserved populations in the rurals and healthcare professionals. So it's always great to be here. Thank you.
Thanks, Paul. Dr. Patterson?
Hey, good morning. This is Dr. Denis Patterson. I'm a physical medicine rehabilitation doctor who specializes in interventional pain management, board certified in both, and been seeing and treating patients with chronic pain in the greater Tahoe area now for about 15 years. Excited to be here. Glad Dr. Dalton has supplied us with a case, and after going through that, I look forward to talking about some recent advancements in the treatment for patients with spinal stenosis. So thank you.
Thanks, Dr. Dalton. Sorry, Dr. Patterson. Dr. Dalton is on my mind today. Okay, so let's go ahead and get all of you introduced yourselves. Dr. Dalton, your turn.
Hi. Sorry, Dr. Patterson, if you got offended by that. I'm not as cool as interventional pain management, but anyway, I'm a DO. I do family medicine and osteopathic medicine in Lincoln County.
Thanks, Dr. Dalton. Ron and Linda Smith, can you please introduce yourself?
Hi, I'm just Ron. I'm not Linda. Anyway, I'm an internist in Reno, and I've been practicing across the street from St. Mary's for over 40 years, and enjoyed practice there. And so thank you for having this.
Thank you. Next, I have Katie.
Oh, sorry, my camera's not working. I don't know what's going on. Anyway, I'm Katie. I'm a physician assistant from UNR's PA program, and I just graduated, so I'm a new grad. And then Dr. Patterson just hired me, so I'll be working in his Carson clinic, and I snuck into his Project Echo to hear this.
Awesome. Thank you, Katie. Is that Dr. Koss?
Yes.
Yes.
Good morning.
Good morning.
Radiation oncologist here for 20 years. I enjoyed this program. Thank you very much.
Thank you, Dr. Koss. Sherry?
Good morning, I'm Sherry Tweed. I'm a registered nurse and the compliance coordinator for the Nevada State Board of Nursing. I work mainly with nurses who have substance use disorder and chronic pain issues. So I appreciate being included in the ECHO Clinic.
Of course, thank you for joining us. Dr. Wadia?
Hi, I'm Gurjeet Wadia. I'm a pediatrician in town. Thank you.
Thank you, Dr. Wadia. Okay, now that we're done with introductions, we'll go ahead with the case first. I will pull up the case form from my side. Okay, all of you have seen this slide. It just states that we record our sessions to put it up on social media, but if you don't want to be recorded, please let us know. We can edit you out. Dr. Dalton always does a fantastic job of this. Please do not disclose any PHI if you're discussing any patient cases. And you just met our pain management team. And this is our disclosure policy and our disclosures from the hub team members. And this is Dr. Patterson's contact information if you want to get in touch with him. With that, I'll hand it over to Dr. Patterson.
Yeah, so I've been fortunate to kind of be at the cutting edge with working on patients with lumbar spinal stenosis and some of the newer advancements that have come along the way. And so I figured today would be a good session just to, kind of share some of these recent advancements and maybe patients that you're seeing and treating in your clinic to see if they would be good candidates for potentially these treatments, especially if they're, currently failing conservative care. So yeah, next slide. So like I said, the main topic that we're going to be looking at is patients with lumbar spinal stenosis. So these are patients who you get imaging that show they got central canal, lateral recess or neuroforaminal and narrowing on an MRI. But not only do they have these findings on imaging, but they also have the clinical symptoms of neurogenic claudication. So that means they've got heaviness, numbness, tingling, weakness, pain in the lower extremities when they are upright and walking. Next slide. So this is a huge problem in the United States. And actually, as we see that our population is living longer, the patients are developing more degenerative changes of the lumbar spine, whether it's disc bulges, hot, swollen facet joints, and one of the key things to key on is ligamentum flavum hypertrophy. So that's the ligamentum flavum posteriorly in the spinal canal can thicken up and push into the spinal canal. So overall, you're looking at about 2 million patients over the age of 60 in the United States have this issue. 94% of the patients who develop the spinal stenosis will have the neurogenic claudication symptoms. And what I'm going to show you here on the next slide is that these patients are very easy to identify. So these are patients that when they're upright or walking, so almost in a neutral or an extension position with their spine, they develop pain and heaviness or weakness or even cramping in the lower extremities. And usually it's pretty consistent. So if you ask a patient, how far can you walk before you stop? They'll tell you they can walk like a block, a half a mile. But eventually they develop these symptoms. And what they find is that when they sit and lean forward, and if you think about the spinal canal, when you sit and lean forward, you're actually opening the central canal of the spinal canal, making it bigger. What you'll find is that then their symptoms will resolve after a few minutes. At that point, the patient can then stand up and walk. They can make it that specific distance once again before the onset of symptoms come in their legs, and then they want to sit down and lean forward. The other thing that you can ask these patients is that if you go to the grocery store, are you able to walk around the grocery store without using a cart? And a lot of patients will tell you, well, God, I can't make it. But if I get the cart and I kind of lean over it, so they're kind of creating a forward flexion moment of the lumbar spine and opening the canal, they're able to walk the entire distance without any pain or discomfort. So these are key things to look on. If you have patients, who have a four-wheel walker, it's kind of the same thing. They're using the walker as almost a shopping cart to kind of lean over and create more space in their spinal canal. Next slide. So if you look at traditional treatment, we've had conservative care. So we've had patients who end up getting on medications, try physical therapy, exercise, when that doesn't improve their situation and they get sent on to pain management usually. And the main thing we look at is doing epidural steroid injections. And a lot of patients end up getting, a series of these injections. So they may get one and the first one lasts for like 3-4 months, then get a second one that lasts maybe for 2-3 months, then get another one that maybe lasts for a month. And what we kind of see is just diminishing returns over time. And if you really look at the medical literature on epidural steroid injections, there's not a lot of evidence out there showing that it helps patients with spinal stenosis with neurogenic claudication. Usually the response is very temporary. And so when patients fail treatment, then we're looking at sending them on to potential spinal surgery and traditional treatments for decompressions and fusions. I think it's about 3% of complication rate with infection and about a 5% complication rate with potential dural puncture or a dural tear that has to be repaired following one of these surgeries. Next slide. So if you look at, kind of the continuum of care, I'm going to introduce some new things. So we've had on the left-hand side, traditionally we've had physical therapy and medications, then we had epidural steroid injections. But now we've got some new things that we can add to the mix. We've got one that's called the mild or the minimally invasive lumbar decompression procedure. And then we have some interspinous process distraction devices. One I'll show you today is called Superion by a company called Vertiflex, which was acquired by Boston Scientific. And then, as I was just discussing in the last slide, the next option patients have traditionally had were open laminotomy or laminectomy, plus or minus a fusion. So I'm going to concentrate on these newer procedures that have been developed and come to the market in the last decade. Next slide. So kind of in my clinic now, when I'm seeing and treating these patients, I've kind of got a new kind of algorithm. Obviously I'm going to put them through conservative care, do the medication management, physical therapy, try, maybe a couple epidural steroid injections. But if we're getting diminishing returns, then, I'm going to get updated lumbar imaging to make sure that we got an MRI within at least the last 6 months. And when I review that MRI, the first thing I'm going to look for is does this patient have spinal stenosis? So I'm going to evaluate the central canal, the lateral recess, and the neuroforamen, especially for the levels that appear that they have symptoms or are symptomatic, and I'm going to see if they have spinal stenosis. The first thing that I'm going to look for is, with spinal stenosis, do they or do they not have the ligamentum flavum hypertrophy? So is the posterior ligament thickened? And the key measurement that we're looking for here is is greater than 2.5 millimeters. What you need to realize is that a lot of radiologists aren't keyed into reading about ligamentum flavum hypertrophy, so they may not call it or even recognize it. So a lot of times I got to track down my own films and look at them myself, try to measure it, and even call the radiologist and see if they'll put an addendum to the report if there is ligamentum flavum hypertrophy. And actually, clinical studies or retrospective review and postmortem cadaver studies have shown that 85% of patients with central canal stenosis, the ligament is usually hypertrophied greater than 2.5 millimeters. So it's more common than we'd think. So that's the kind of the first question I have. Do they or do they not have ligamentum flavum hypertrophy contributing to their stenosis? The second thing that I look for is instability. So I'm going to get some dynamic lumbar x-rays. I'm going to do flexion extension views, and I'm going to make sure that they don't have a unstable spondylolisthesis, because if they do, an unstable spondylolisthesis is a surgical situation in which the patient probably isn't going to do well with conservative care. They need to have their spine stabilized, and at that point, it's probably more of a direct surgical referral instead of looking at these new procedures. So in this algorithm, if you look at it, if the patient does have ligamentum flavum hypertrophy, then I'm going to look at possibly doing the minimally invasive lumbar decompression procedure, or the PILD is also the other acronym that is used to describe it. If the patient has no ligamentum flavum hypertrophy, but they do have spinal stenosis, then I'm going to look at doing an indirect decompression, which with one of these interspinous spacers at that level. And then last but not least, if the patient has any instability, I'm going to look probably sending them off to the surgeon for a decompression and infusion. Next slide. So let's look at mild. The nice part about the mild procedure is it's actually eliminating the root cause for the patients. And like I said, 85% of patients post-mortem have hypertrophic or swollen ligamentum flavum hypertrophy. And so if we look here on the far left of the screen, you can see a sagittal view of the lumbar MRI. You see the arrow pointing in, that's showing the ligament is hypertrophied and it's starting to push into the canal. If you look at an axial just next to it, you'll see the ligament is kind of outlined there. And it usually what it does is causes tenting of the spinal canal. So instead of it being nice and round, that ligament's pushing in, it causes tenting of the canal at that level. And when you outline it, usually if you're looking at the images yourself on PACS, you can actually right click, it'll give you a measurement tool, and you can actually start and measure how thick the ligament is and how much it's contributing to the, or how far it's pushing in the canal. The nice part about the MILE procedure is that even though I talked about patients with multifocal stenosis due to several sources of pathology. So one, they can have a disc pushing in the canal that can contribute. They can have big swollen facets, or they can even have the ligament pushing in. What we find is that resolving one of the issues may resolve or improve their symptoms. You don't have to address, all three things. You don't have to address the facets or the disc if you can get that ligament to thin out by doing this procedure. Next slide. So if you see a patient with ligamental flavum hypertrophy, you're looking for a minimally invasive way to deal with it. Since they haven't improved with conservative care, what you can do is the MILE procedure. So this is just pictures of the procedure being done at L4-5. So what we end up doing is we end up taking a trocar, we'll touch it down on the posterior superior third of the L5 lamina. Once we've gained access there, if you look on the left, we end up using a rongeur. So we'll get a cross or a contralateral oblique or a CLO view. So it's almost like a 45-degree view with the X-ray or fluoroscopy, where we can see shelving of the lamina. And then what we end up doing is we put this rongeur underneath the lamina above, and we'll take pieces of ligament and bone with the rongeur, and we'll turn it upside down and get pieces of the top part of the L5 lamina and part of the ligament. And we'll kind of do it in a medial to lateral fashion. So you'll do the left side, and you'll do the right side, repeat the steps. Once you've created space with the rongeur, then you move over to the right-hand side. On the right-hand side, we'll end up using what's called the tissue sculpture. So that's the end of the tissue sculpture coming out of our working cannula. We can dig the ligament out at that level. So the rongeur on the left is going to take pieces of lamina plus ligament. On the right-hand side, after we've created enough space with the rongeur, then we use the tissue sculpture to remove the ligament by itself. And what we find is that just removing small amounts of the ligament almost decompresses or changes the pressure at that level and makes the patient less symptomatic. The nice part about this procedure is there's no equipment. The incision is the size of a hole punch. And you can, through that one incision, you can do multiple levels. So I've done up to 3 levels through one small incision like that. At the end of the procedure, there's no sutures, there's no staples. You just use Dermabond and put a steri strip, and the patient can return to normal activities within 24 hours of having the procedure. Next slide. So now let's talk about the other option. So if the patient doesn't have a swollen ligament inflatum hypertrophy, but they have spinal stenosis, are they, what are these interspinous process distraction devices? So next slide. So we'll talk specifically about Superion. Like I said, it's made by a company called Vertiflex that's been acquired by Boston Scientific. It's an FDA-approved spinal implant to treat spinal stenosis. It can be used for central canal, lateral recess, or neuroforaminal stenosis. And as I was saying earlier, these are patients that are easy to identify, that their symptoms resolve with sitting and leaning forward or bending forward or leaning over a shopping cart. The nice part about this procedure is that it is completely reversible. So you can put the device in, the patient can try it. If it doesn't work, it can be taken out. That is one of the downfalls with the procedure, though, is that patients who don't want hardware, the MILE procedure, if they have a swollen ligament is probably a better option because nothing is left behind. In this case, we are leaving a metal implant between the spinous process. Next slide. So it's a pretty simple procedure here. You basically make a midline incision at the level of interest. You end up putting a series of dilators down between the spinous process. Once you get the working cannula in place through the dilators, you actually will size between the spinous process how big the space is. You'll pick an implant, whether it's 8 millimeters up to 16 millimeters. You'll put the implant in, it'll be closed. And as you can see here, the implant then is opened. And it's almost kind of like a field goal between the two spinous process, and which I'll show you here on an AP and a lateral. It kind of fits right between the spinous process. And then you kind of tap it down so that it goes over the interlaminar space just posterior to it. The more posterior the implant is, the greater stress it can put on the spinous process and potentially cause a spinous process fracture. It's pretty rare, it's less than 1%. So you want to make sure you push that implant down. So if you see the middle picture here, the implant's open, but it's more posterior. On the right, we've pushed it down so it's as deep as it can be. Next slide. And so here's just kind of a quick procedure flow. We get our quick incision over the level of interest. We put a series of dilators down on the left. Once we get the series of dilators down, we'll measure the space here in the middle. Once we've measured the space, we'll put the implant in, we'll open it up. And then with this procedure, usually it's an incision about the size of the dime. We'll have 1 or 2 deep sutures. And typically I'll put a couple staples over the skin to hold it closed. Post-procedure, these patients, we don't want this device to migrate. We want it to spar in place. So it's usually recommended that the patient limit, extreme BLT, bending, lifting, and twisting for about 4 to 6 weeks. And then at that point, usually get them started in a walking program or physical therapy to get the benefit. Next slide. And the great part about this procedure is it's non-disruptive. We're not changing the patient's spinal anatomy. So if it does fail, the patient can still go get a decompression or fusion by a surgeon. The incision is very small. It doesn't require general anesthesia. Actually, in the cases that have been done, they've been done under local conscious sedation in general, depending on the surgeon's or the patient's preference, and it's FDA approved. Next slide. And then this is kind of what I was saying. This is at L3-4. You can see almost looks like a spider is how I describe it, but the implant is almost kind of like a field goal. The legs go up and around the sides of the spinous process, and then posteriorly, it'll be pushed down to the interlaminar line posteriorly to prevent extension at that level and hopefully eliminate symptoms. Next slide. And I think that's it. I just wanted to highlight these procedures and then leave it open for discussion if patients have any questions regarding these treatments. The nice part about both of them is, like I said, they're less invasive than traditional surgery. In both cases, I don't think there's ever been a reported infection or dural tear, which can happen with an open decompression and fusion. And as I said, neither one of these procedures burn bridges. So if they help the patient, great. If they don't, patients can still be passed on to the ortho or neurosurgeon for the traditional decompression and fusion procedure. Any questions for me?
Yeah, hi, this is Ron. So 2 questions are, who's doing this in Reno, and is there good insurance coverage for it?
So yeah, so there are approved Medicare codes. So traditionally, the majority of the patients you're going to see are going to be Medicare population, and Medicare Advantage plans through the Social Security Act have to cover any procedure that is got a Medicare code. So Medicare, you've got widespread coverage for all plans. Commercial insurance, it's hit or miss. So you usually recommend doing a prior authorization or pre-certification process to see if you can get it approved. And just depending on the specific insurance plan and their policy, it may or may not get covered. In Reno, there's probably a handful of us interventional pain guys doing these procedures. So it just depends on what clinic and what physician. But what's nice is with both companies, you can go to their website, you can put your zip code in, and it can share any provider in the area who's trained and is actively doing the procedure. It can give you a list of those providers.
All right, thank you.
Thank you.
During the healing process from the patient's experience, do they have to wear a back brace, or does the bone actually form around the implant? What is the healing process like for the patient?
So for the mild procedure, it's since you've dug out the ligament, there's really no restrictions the next day. And in long-term studies at the Cleveland Clinic and CMS, which did a 2-year study, showed that there developed no instability at that level. So I've had patients who've gotten the mild procedure literally on a Friday at 3 o'clock, had a tee time for golf at 9 a.m. the next day, and they've made their tee time and played 18 holes of golf. So there's really no limitation there. I don't put them in a back brace. The Vertiflex procedure, on the other hand, or the Superion, you do want to make sure it scars into place. I have not used bracing for patients, but I have heard of other physicians use bracing for that first 4 to 6 weeks. And the reason why they're using bracing is more of a reminder to the patient that they've had a procedure and that they need to think about, how much they bend, how much they lift, and how much they twist. But I haven't prescribed one for a patient. I've just, warned them, you should do minimal lifting, bending, and twisting for the first 4 to 6 weeks.
And then follow up, do you see them a couple of days afterwards and then a couple of weeks afterwards?
Yeah, so I usually want to see them back 10 to 14 days. With the mild procedure, I just want to make sure that the dermabond and the steri-strip have ensured that the incision has closed. With the Superion procedure, they're going to come back in and I'm going to remove their staples at 10 to 14 days, since that incision's a little bit larger. And usually at that 2-week period, then I do want to get them in a physical therapy program to start a walking program to maximize the results.
There we go. Okay, thank you.
No problem. The other thing that you can consider too is, if for the patients, you can do the mild procedure, and if they haven't improved within 3 months, you can look at doing a Vertiflex next. So patients, it can kind of go in that order. Once you put the Superion or the device, I have heard of some interventional pain physicians, trying to dig the ligament around after it if it doesn't help. But that just sounds like a headache. So I'd rather, do the procedure where I take care of the problem. If it doesn't resolve all their symptoms, then put the implant in second. And that's also, in my opinion, least invasive to more invasive. Any other questions for me?
How difficult is it to remove the Superion product?
It's not difficult at all. You just need to make a little bit bigger incision. You can reattach the prior equipment that you use to open the device. You can attach it using fluoroscopy. You can attach it to the device and you can actually close the device and pull it out. If that doesn't work, then like I said, it's just usually a little bit bigger incision and just kind of get some clamps in there on the device and pull it out. You may even have to maybe, bend some of the teeth that go around the spinous process, but I've never not had a problem. And I've only had to remove a few, but I have not had a problem ever removing them in the past. Any other questions?
Other than instability, what is the mechanism of action by which a fusion actually helps?
Well, you're exactly right. I think the only reason for fusion is if they think there's instability at that level. And, really a spinal fusion isn't going to, it's not going to help the stenosis, right? You have to actually decompress the level with either a laminotomy or a laminectomy in order to help the symptoms. I think the spinal fusion then is just to prevent if they believe there's going to be future instability or if there's current instability. That's the only reason for adding the fusion.
Thanks.
No problem. Any other questions out there? Okay, well, it looks like we'll have 5 minutes to spare today. End on time for